Hello, my name is Anish Kadakia from Northwestern University, and today we're going to discuss the InternalBrace ligament augmentation repair. My experience, some of the biomechanical and clinical data, and discussion of some of the quote-unquote competition or competitors that are out there that are trying to mimic the excellent results that we're able to achieve. Let's look at some of the data about standard ATFL rostrum reconstruction. What we know is that unprotected motion causes lengthening and failure of the reconstruction. So although we feel taking the ligament, putting it back together and tightening it is okay, unfortunately it is not. When you look at using suture anchors, which are superior with regards to initial stability, they still do not provide enough rigidity for the repair for the long term. And this is just a biomechanical study showing how rigid and stable the internal brace is to stress. Why do I use the augmentation with the internal brace? Because it is better for the patient based on the data we have. Early motion is critical, it's better for collagen, and the internal brace allows me to achieve that without lengthening. It's not just about the faster rehab, that's kind of a short-term goal. It's very important for our athletes, but for our non-athletes, the goal is that after a year, they're still stable, they don't have to come back and see you, and they're not getting that instability and that risk for arthritis. The internal brace allows reproducibility of the positive outcome. I've done over 200 procedures, and I want to emphasize it's not just for the lateral ankle. That's clearly where I started, but I use it all over the foot and ankle, and it's allowed me to do things I was unable to do without the internal brace. When you look at efficacy and safety, 1.5 million fiber tape bridging constructs have been used with really the best safety compatibility records in orthopedics, which is not the case for the competition. Collagen ingrowth is a very unique aspect of the internal brace because of the collagen-coated fiber tape that we use. This is a case from a colleague of mine that had a large cavus deformity that underwent a reconstruction and unfortunately needed to be revised because of subtalar instability, not because of the ankle joint. And during his revision, he noted peroneal tendon scarring, but also that the internal brace was completely coated with collagen. You can't even see the blue. So during his revision to do a non-anatomical subtalar instability, he had to remove the collagen-coated internal brace. It's actually very hard for him to find. So you can see here, as opposed to a synovitic reaction or a foreign body reaction, you actually have positive collagen ingrowth on the fiber tape. This is a white paper that we did kind of backing up the clinical data that we have. The collagen-coated fiber tape, and the green identifies live tenocytes, viability of tenocytes. You can see the collagen-coated fiber tape is superior to any of the competition. And red, if you look at the bottom two slides, red is actually tenocyte death. You look at live cell density on a graphical manner, you can see, statistically speaking, the collagen-coated fiber tape is superior to all other products out there. And this is the only one that has collagen coating. What would be ideal for ligament augmentation? A native ligament is not a rubber band, and that seatbelt analogy actually is probably the best one. It is static, it's supposed to hold you in place. Well, the native ATFL doesn't really move. It's 0.4 millimeter of excursion in a normal population with this particular ultrasonography study, and if you're symptomatic, you're unstable, 1.2 millimeters of excursion causes you to have ankle instability. So we know augment should not have laxity or elasticity because that would make no sense. When you look at another study, the data is reproducible for how much a ligament has excursion, and the answer is it does not. The mean change in this ultrasound study was 0.1 millimeters, and a symptomatic patient had 1.9 millimeters, or almost 2 centimeters of laxity. We have a lot of studies to support the clinical efficacy of the internal brace. Multiple studies show that they have superior outcomes, return to exercise is fast, and one thing that you'll notice is that there's not a lot of complications. If you look these studies up, they do not have product-related complications. No studies without surgical complications, but it is not related to the product. So the internal brace ligament augmentation is safe, it's effective, it's better for the patients. This is a retrospective study that was done by Dr. Coetzee and his team, and you can see the mean return to sport was superior with the internal brace. This is a prospective randomized study by Dr. Cohen, Watson, Dr. Rigby, Coetzee, and Vora. This is the type of study that we want in orthopedics. It's very rare when you look at level 1 studies. 59 patients standard brostrum with the suture anchor, so appropriately done brostrum, and those that had the primary pair augmented with the internal brace. When you look at early follow-up, return to sport, it was superior in patients that had the augmentation. Patients who were in the standard group, some of them did not return to activity, and it's clearly more patients were unable to return to sport that did not have an augmentation. So in this prospective randomized study, the internal brace did better. Patients without the internal brace had to quit from the accelerated rehab, and there's just no question that the internal brace was superior. When you look at the competition per se, when you look at Artelon, the argument that they use to promote their product is that it is elastic. It absorbs and rebounds. That's not my slide, that's their slide. Absorb and rebound would be the absolute opposite of what you would want in a ligament. Remember, a ligament does not move. Its elasticity is only 0.1 millimeters in the normal population. When you look at theirs at 125 newtons, which is about average for the amount of strain you would put on the ATFL, they have 2.4 centimeters of excursion. And that is clearly above and beyond someone who's symptomatic. So not only does it have elasticity, it is so elastic it's actually worse than a patient that has ankle instability. This actually doesn't make any sense whatsoever when you talk about ligament reconstruction. When you look at the data in PubMed, there's 121 articles when you type in the internal brace and you isolate that, and there's actually 153 for Artelon. Well, you may say, well, look, they have more studies, but it's not quantity, it's always about quality. So if you look at what they are published on, you can see there's foreign body reactions, poor outcomes with Artelon. It's actually mostly, quote unquote, not ideal or bad data. This is a failed Achilles tendon rupture that was augmented with Artelon. It's a standard Achilles rupture where we know that the mid-substance speed bridge is phenomenal, does great, minimal reaction. Patients have minimal scarring, and you can see here this patient has the opposite. Pain, weakness. The Artelon did not get absorbed. It was still present, and Dr. Mafuli is a very well-respected surgeon who's a master of the Achilles tendon. This is another article looking at a systematic review of Artelon. 11 articles for CMC arthritis where it was actually used initially. And so what were the areas of agreement? Now, typically when you look at a systematic review, areas of agreement are positive things. There is nothing positive that they could possibly come up with. Artelon is not recommended. High revision rate was noted in every article. Worse outcomes. Why would you use this type of a device? And we should just be aware that it's not helpful to the patient. There's another study, prospective randomized study, and you may argue, well, they have a randomized study too, but what's the conclusion? Well, swelling and pain was more common in Artelon, 6 required removal, and they had significantly better pain, but those that did not receive the Artelon. Now they're trying to promote this for the foot and ankle. But when you look at the data, none of those are procedure specific. Those complications are body specific. The rejection rate, inflammation, worsening pain, that's not particular to the hand, that's just from the product itself. So they stayed here, soft tissue reconstruction with Artelon for multiple foot and ankle applications. And you may assume this is going to be 20, 30, 50 procedures. Well, let's look at the summary. 3 cases, that's it. So they're using the word multiple in the most minimal way you can. It gets even better, so it causes foreign body reaction. This is a multiply published complication with Artelon. 3 cases of foreign body reaction specifically related to the implant itself. So physiologic, body specific, not procedure specific. No surgeon would want this and no patient would want this if they knew the data anywhere near their ankle joint or anywhere in their body. If you're going to get a foreign body reaction, why would you put this in? The internal brace is superior for ligament augmentation and is superior to any other product that tries to mimic the efficacy and the mechanics of the internal brace augmentation. We have multiple clinical articles showing both safety and efficacy, which nobody else does. Arthrex is the only company to have collagen coating to promote tenocyte growth. Artelon has proven foreign body reaction and is too elastic for ligament repair. The internal brace is biomechanically stable, promotes collagen growth, improves clinical outcomes, and should be used and I use for all my ligament reconstruction. Thank you very much.